Ladies and gentlemen, boys and girls, welcome once again to the Indian Journal of Anaesthesia Editor's Insights podcast. We are on the second edition of our September 2024 podcast. In this podcast, I'm thrilled and honored to have one of the renowned figures in regional anesthesia and pain medicine with us. We have Professor Vincent Chan, who has joined us from Toronto to enlighten us in this episode of our podcast. Dr. Chan earned his MD from the McGill University in 1980 and completed his anesthesiology training at the University of Toronto, where he also received board certification in 1986. Dr. Chan is widely recognized as a global leader in ultrasound-guided regional anesthesia, receiving the prestigious Gold Medal Award from the Canadian Anesthesiologists Society in 2009. His leadership extended as president of the American Society of Regional Anesthesia and Pain Medicine from 2009 to 2011. Among his numerous accolades are the FRCA Fellowship by election from the Royal College of Anaesthetists, UK, the IARS Teaching Recognition Award for Achievement in Education, and the Distinguished Service Award from European Society of Regional Anesthesia and Pain Therapy. Professor Chan also serves on the editorial board of Anesthesia Analgesia Journal, the RAPM, which is the Regional Anesthesia Pain Medicine Journal, and also on numerous international journals. With over 200 peer-reviewed articles, 14 book chapters, and 80 scientific abstracts, Professor Chan has made significant contributions to the advancement of anesthesiology, especially regional anesthesia. He has held key roles at the University of Toronto, where he is presently the Emeritus Professor, including the Chair of Research Committee, and he has served as a mentor to more than 40 postgraduate clinical and research fellows who are actually leading the field of regional anesthesia presently. In this way, he has cemented his legacy in both education and clinical practice, and it's our honor from the entire team of Indian Journal of Anaesthesia and the podcast team to have him. Welcome to the podcast, Dr. Chan.
Thank you. I'm also very thrilled and honored to be here.
So, Professor Chan, the reason why we have you as a guest today is that we have been having numerous publications on regional anesthesia related research in Indian Journal of Anaesthesia this year. And no regional anesthesia technique can be done without local anesthetic. And we know that apart from the local anesthetic regional anesthesia effect, having a regional anesthesia effect, it does have other systemic effects such as antiarrhythmic effects, wound healing effects, effects on CNS function, antithrombotic. So there are multiple effects of local anesthetic which many people might not appreciate. And all of these effects are dependent on the plasma levels. And the plasma levels of local anesthetic are key to having a therapeutic effect and also the toxic effects that we see when they reach a toxic threshold. So the reason we have you here is to discuss more in depth about the importance of plasma levels of local anesthetics. And to start the discussion, I would like to ask you a question as to what are the key principles behind determining what is a safe dose of a local anesthetics and how does it vary between all the different local anesthetics?
So I think this is an important topic because, as you said, we use local anesthetic for regional anesthesia. That's what we use it for most of the time. And when we talk about a safe dose, that means if we use too much of local anesthetic, it can get into its toxic side effects. And we will see neurologic and cardiovascular complications. And when we give a local anesthetic dose, for regional anesthesia, we have to give it into a tissue compartment. We inject it, let's say for peripheral nerve blocks, we are putting it either in the upper limb, the lower limb. Now we do a lot of field block, we put it in the trunk. We use it for local infiltration. We put it subcutaneously. And then for epidural, obviously, we put it in the epidural space. So we put local anesthetic in different tissue compartments. And after the local anesthetic is injected in these compartments, it depends on how well perfused those tissue compartments are. The local anesthetic, will be absorbed by the vessels, and it would now then distribute into the blood compartment. And that will lead to a buildup of the local anesthetic blood level. So in general, the more local anesthetic we use, inject in the tissue, the more likely that there will be more local anesthetic absorbed into the bloodstream, and then that would lead to a higher local anesthetic blood level. So I think when we look at the safe dose, we have to ask about, first of all, look at the drug, the intrinsic property of the drug. Potency, the more potent a drug is, the more toxic it is. So the potency and toxicity go hand in hand. So for example, we know that bupivacaine and ropivacaine are more toxic and more potent than lidocaine, and that's why we have to use less bupivacaine and ropivacaine than lidocaine. So we usually will look at the drug and we calculate as milligram per kilo. So the safe drug, the safe dose, the maximum dose recommended for bupivacaine and ropivacaine will be lower than the lidocaine. So if you look at the recommended safe maximum dose, you will see a table in all the standard textbooks. There's only one table for the recommended safe dose, and this to me, it's one has to realize that this is a safe dose for single shot injections. I don't think there is another table for longer term or continuous infusion administration. So this table is for single dose injection. So what we're trying to do is we give the drug, there will be systemic absorption. We want to make sure the local anesthetic blood level does not reach a toxic level that the patient will suffer local anesthetic systemic toxic side effects. So as we know, the minor toxic side effects are the metallic taste, perioral numbness, tinnitus, maybe a little bit of lightheadedness or dizziness. So those are the minor local anesthetic effects. So as the local anesthetic blood level rises higher, then we may see more serious local anesthetic toxic side effects such as muscle twitching, blurred vision, auditory disturbances. And when it go even higher, one may see the seizure and the CNS depression like a coma. For the cardiovascular side, again, we may initially see some arrhythmia, hypotension. Then when it goes higher and higher, you may see the ventricular arrhythmias, and the worst obviously is cardiovascular collapse and cardiac arrest. So in order to determine the safe dose, we have to first of all know the toxic local anesthetic blood level. We want to give a dose that would not exceed a level of blood local anesthetic that will reach the toxic, that will cause toxic symptoms. So that's how we look at the safe dose. But having said that, I think one thing that we generally don't talk about is we treat everyone the same. The same dose given to everybody will not achieve the same level. Some people will higher level than others. So for that reason, please always remember what is published in the literature, the safe dose, that is for the general public. But there you will see exceptions because some people, for some reason, they are able to absorb the local anesthetic much faster and achieve a much higher level, and you may see toxic side effects. So it's always good to use the lowest dose possible to achieve the anesthetic effect.
So regarding the therapeutic and the toxic range that we see, you did mention that there are different dosages, especially when we calculate milligram per kg. Now, you also mentioned that different sites have different rates of absorption, and we very well know in all textbooks they do mention the varying absorption or the varying toxicity of different routes, starting with something like an intercostal being very high, caudal being very high, then we come down as we come to infiltration. Now, how does one actually calculate? Now, example, now if somebody says, yes, I'm calculating for 3 milligram per kg body weight, but is this the dose I'm going to give it to my surgeon to infiltrate for a local infiltration anesthesia or analgesia during a knee surgery? Or is it the dosage that I'm going to be using for an epidural? So how does somebody determine this 3 milligram per kg and then dose accordingly?
I think we have to work backwards, and in order to know what is the toxic blood local anesthetic level is, I went into literature and found that to determine this, we usually use volunteers. So they will be given as infusion of local anesthetic. Let's say you choose lidocaine. You give them an infusion of lidocaine enough that they will begin to experience minor toxic symptoms. At that point, they will do a blood test, look at the blood level of local anesthetic. So then we'll determine what is that level that causes local anesthetic toxic symptoms. Again, we will have a mean. What is reported, like say for lidocaine, most people say it's 5 microgram per mil. That is the high upper level, acceptable level. But this again is the mean. You will see that there is a range. Some people, some volunteers will experience toxic symptoms that are lower than 5 mics per mil, and some will be higher than 5 mics per mil, microgram per mil. So that what we see 5 is the mean, the general. Same thing for bupivacaine. People talk about 2 microgram per mil. Again, that's the mean. For ropivacaine is about 2.2 microgram per mil. So once you have determined what is the acceptable blood level, then you go back to the dose. When you inject a dose, then again you can measure the blood level and see what level will arrive at this level. But again, when we look at the table published in most textbooks, that to me, what I understand is that maximum dose is for epidural administration. So lidocaine 5 mics per mil at 5 milligram per kilo for plain lidocaine, and 7 milligram per kilo for lidocaine with epinephrine. So as far as I know, that is for epidural administration. But we cannot find another table for local infiltration or peripheral nerve blocks. There is only one table in the published textbook.
We see a lot of fascial plane blocks coming in ESP. We have the tab blocks and much more in the entire range of fascial plane blocks. So what is your take if somebody were to dose? Now, let's say we're using ropivacaine and the books recommend 2 to 3 milligram per kg. Now, there are a lot of papers in the literature in very highly reputed journals where the dosages have gone up to at least 5 or 6 milligram per kg, and they've still reported normal blood levels. So how does somebody work with this?
This is the tricky part. I think more pharmacokinetic studies need to be done, and there are not so many papers published on blood levels. So when I look at the blood levels in general, we know that for paravertebral block and transversus abdominis plane block, the TAP block, their blood levels generally are higher after local anesthetic is given. They are higher, definitely higher than erector spinae plane block and the quadratus lumborum block. So that's what we know. The TAP block, probably the blood level will be about the same as epidural, or maybe slightly higher. Why is that? probably the abdominal muscle tissue perfusion is quite well, they are quite well perfused, and the paravertebral space, again, is very richly vascularized. So that is why we see a higher blood level. But having said that, generally speaking, when you look at the report of toxicity, usually that happens in the earlier days of when technique was adopted. But lately, I cannot find any more. Maybe people stop publishing toxicity, or their reports will not be published, or I don't know why. People may be now more aware of the maximum dose. They then put it in the syringe, diluted to the desired volume. Also, most people now would add some epinephrine vasoconstrictor to decrease the systemic absorption. So by and large, I would say, even in our institution, I don't hear about toxicity anymore. People seem to know the maximum dose diluted to the desired volume, add epinephrine. That seems to be very safe.
This brings me to actually three questions listening to you. One is, after how long after a block, especially a facial plane block, do we see peak concentrations? One. Second is a very controversial discussion that is happening in the scientific circles for a while, that whether the facial plane blocks have the effect not only at the local neural structure but also systemically, because they get absorbed and there is a plasma level which is in the therapeutic range, leading to a systemic effect. So both the questions are probably linked to what you actually spoke about.
I think the peak time, the peak level that we observe for most of the regional anesthetic technique due to systemic absorption, 30, 40 minutes. So usually within an hour, the peak time should have occur within an hour. So usually 30 or 40 minutes. With regard to the plain block, I think the frustration with plain block is many times we cannot see or test the sensory level. We cannot see the objective evidence of the block. That's why we are guessing, is it working locally where we inject, or is it a systemic effect? And it's true that few block local anesthetic administration will give rise to blood levels, the local anesthetic blood levels. And it is true that, there will be increase in blood level. But is it due to the blood level or is it not? I feel that this probably is a combination, because if it is just due to the plasma, the blood local anesthetic concentration, you would expect it to see a decline with time. And why would a plain block effect lasting more than 6 hours, 12 hours, and sometimes claim to be 24 hours? I don't believe that can be explained by the systemic level. I don't think it is not a sustained local anesthetic blood level. So I don't believe that will be the reason for the analgesia effect that we see. Because if you look at the IV lidocaine infusion, you will need a sustained level. You would need an infusion in order to achieve that. So that's why I don't believe it's just purely a systemic effect that we see after the few block local anesthetic administration. But that's just my personal feeling and belief. I don't have any good evidence to show that. And I think it is important that more and more studies need to look at a plain block analgesic effect plus its local anesthetic blood level achieved compared to maybe an IV lidocaine infusion, and then look at that comparison and then have a better sense whether we should do plain block on every patient preemptively.
We spoke a little bit about studies and we spoke about what can be done in research. So I would like to request Dr. Rakesh to join the conversation now because I'm sure he's got a few questions for you.
Thank you, Dr. Murali Thondebhavi, to bring about such a great insight about the regional blocks. And greetings once again, Professor Vincent Chan, to join us. Greetings from all the team of Indian Journal of Anaesthesia and IJA podcast team. You have very nicely summarized various aspects. So we were talking about, Murali was also mentioning about the absorption. And we have read it, and you being the role model in this arena of regional anesthesia and analgesia, we were talking about the pressures by which the drugs are injected into perineural space. Now we have arena of fascial plane blocks. When we talk about fascial plane blocks, the drug seeps into a certain fascia. So there are two things. Have you have any idea or suggestions for the listeners to us that what should be the pressure while we are injecting even for the fascial plane blocks? Because we understand that this is not a smooth area where the drug will seep in. There will be a lot of fibrosis, adhesions, and the space has to be created. So are we very concerned that if the pressures are too high while injecting, will it lead to more amount of absorption of the drugs because muscles or the fascias around, they have good vascularity? Any concerns about the pressures?
I am not aware of any studies looking at different injection pressure and the blood local anesthetic concentration and how it affects systemic absorption. I'm not aware of that, but certainly when we do plane blocks, depends on what plane we're talking about. When we do it in the pericapsular nerve group injection in the just above the bone surface between the muscle and the bone, that plane is so tough, But so that's what I'm trying to say is tissue planes are not all made the same. Some are so much tightly bound. You need a much high pressure, and sometimes I need to use two hands in order to inject, and it's a scary experience. But then when we do a tap block, it's very easy. It was very easy to inject for the pectoral muscle layer, again, very easy to inject. So generally, I don't need to use a lot of pressure. But to scientifically answer your question, I don't know the answer because I have not seen any studies examining the relationship about injection pressure and the systemic absorption of local anesthetic in the fascial plane.
I think, can we urge the researchers across the globe that they should look into this area also, that because now I know there are commercial pressure regulators available while giving regional blocks. So can we urge the researchers across the globe to look into this arena also? And you rightly mentioned that all the planes are not same. Some will be tightly adhered and some will be softer, you rightly mentioned. I think that's a big food for thought for the researchers across the globe to look into this area also, that how much pressure should be given and does it have an impact on the onset and the duration of the block on one side, on the other aspect, the toxicity profile. The
I
second
think
question.
I think it's definitely worth looking at. But again, the emphasis is incremental dosing. You don't want to inject the whole dose at the same time. So regardless of how much pressure, you will do incremental dosing to be safe.
So, Dr. Rakesh, recently I saw a poster which was highlighted on Twitter during the recent European Society meeting in Prague, where they looked at fluid dynamics. It was a study on fluid dynamics, and they showed that slow injections have better spread in fascial planes and therefore probably have a better efficacy of the block. So that probably is something that people can do research on.
Absolutely. I think this is the second area. And I think what Dr. Murali mentioned, when we talk about the fascial pain blocks, as he rightly mentioned, that if you are giving the drug at a slow rate, probably the seepage across the plane is to a larger extent. And as a general understanding, if the pressures are too high, it would be focal at a particular area, maybe increasing the absorption, though we do not have the data. So now when we say the ultrasound guided fascial pain blocks, majority of the blocks as a conventional technique usually mentions at a site. The probe is usually at a site and the drugs is injected. When we talk about, say, a brachial plexus block, we usually say, see the halo around it and see whether the all nerves are dipped into that local anesthetic agent. Are you also looking into this area? Again, I think further research is required. Can we scan across the plane to look for whether the drug that we're injecting, say 5 ml, 10 ml, 20 ml, and we can just see that, yes, this volume is sufficient because the plane has been filled with the required volume of drug, and the target nerves in those areas are to be filled. So are you looking for, I think you are one of the pioneers in this, are you looking for describing the techniques in a little modified way to scan across the plane to look for the effectiveness or the area that needs to be anesthetized by giving that fascial pain block?
This is one of the frustrations I have with plain blocks before I retired. So I do look at the spread under ultrasound, but the spread, number one, even the spread, extent of the spread, doesn't really predict, in my opinion, does not predict the success of the block. You would think that the wider spread would be a better block than one that is more limited. But I'm not so sure I can see that relationship. I try to achieve that large spread. I think the problem again with pain block is we don't see the nerve fibers. We don't know where they are. So yes, for most people, maybe that when you inject over this region, you will get a good block because you expect the nerve to travel through that area. But there may be variations, and we don't know where they are. That's why we try to cover as wide an area as possible. And that's why we try to use as much volume or local anesthetic as possible. So we just flood the field in order to get the result. And since we don't know where the nerve fibers are, and that's why we would never get 100%. We will see some inconsistencies. That's my belief. Until you have a clear target. So the plane is there, but where are the nerves? We are not targeting just to the fascial plane, but we are looking for the nerve fibers within that plane that we don't see.
So is it a possibility, like some of the researchers, even from India, they are doing a good amount of cadaveric research and to look for whether we are bathing those nerves, and obviously there are a lot of anomalies and differences. Do you think this can be a future research work also for looking for that, whether we can identify nerves at least in cadaver and know that this is the area to be bathed with the local anesthetic agent?
I have done a number of cadaver studies, and I realize what is important to remember is just because we see staining in the area, it only means that the fluid has spread this extent, but it does not correlate to a neural blockade, because in order to achieve a block, it's not just the local anesthetic getting there, but it has to achieve a certain concentration, right? It has to have high enough concentration to bathe the nerve and exert the block. So the cadaver study has its role. Its role is to prove that, local anesthetic at this volume will spread this much and the variations. But it doesn't correlate to a block. The block effect is not just where the dye spreads to that area. So when we look at ESP block or whatever block, you will see local dye in the epidural space. But it doesn't mean that we will see epidural effect, block effect after ESP block. So those are the subtle differences. So cadaver workshop dye contrast studies have their important roles, but I don't think it would address the actual neural blockade effect that we want to.
A lot of research needs to be required to understand these basic nitty-gritties. We fully understand that fascial blocks clinically are useful. They provide good energies here. But now looking for those aspects, I think you have opened up a lot of food for thought for researchers to come out for looking for these aspects also. And what are your thoughts regarding the use of adjuvants? We know that a number of adjuvants are being used for central neuraxial blockade, even for plexus blocks with variable efficacy and other things. And the studies have also found that yes, certain receptors exist even for, say, infiltrative blocks like opiate receptors. How do you perceive that there will be a role of various adjuvants, most commonly read like dexmedetomidine or ketamine or opiates, for the facial pain blocks? Because we do not know whether those receptors are there, whether it is happening through receptors, or we're just talking about that they are absorbed from the surface and they have a systemic effect. So how do you perceive that future research of various adjuvants have some role for facial pain blocks?
I personally very supportive of using adjuvants or additives with local anesthetic for peripheral nerve blocks, for example, as long as the adjuvant, the additives is preservative free. Otherwise, I don't see the downside of using it. Everyone would tell you, yes, you're using it off-label, but we know that dexamethasone has been used for so many years for epidural steroid injections, and so it's not an issue with neurotoxicity, in my opinion. So yeah, those finding studies looking at what dose is the best, and then whether it is good to use it perineurally, add it to the local anesthetic and inject for the block, or to give it IV, right? Because we know that IV dexamethasone methadone also can prolong the duration of analgesia. So those studies need to be done in order to answer all the questions: how much to give, and also how to give it, whether to give it just simply IV or give it with the local anesthetic. With other drugs, again, the ketamine and all that, I have looked at the data, and the data is some more mixed. I think dexamethasone is very clear. It's uniformly very helpful. For dexmedetomidine, again, the data are very encouraging, but usually we don't use it is because of the cost. Maybe not, it doesn't cost too much in Asia, but in North America, still quite a bit. And also, one vial, unless you fractionate it, otherwise it's a waste. You use just a very small dose. And all the others ones, I think it's worth looking at, but by and large, so far, I think the dexamethasone is one that is most promising and clinically useful.
I think you have really opened up the Pandora of opinions and ideas for people to bring up more research so that we can bring it in a more evidence in coming near future. And with your insight and expertise, I'm sure that many researchers will have more research questions to work on those areas. So thank you once again, Professor Vincent Chan, and back to Dr. Murali for further remarks or further questions. Dr. Murali.
Yeah, I do have further questions, Rakesh. Professor Chan, we'll go back to the comment you made about a single dosing and an infusion. So how does somebody calculate a dose here? Now, if we say 3 milligram per kg body weight, are we looking at just one single block, or if somebody's put a catheter there, is it a 24-hour dosing?
So that dose again is single shot dose, injection dose. We don't know how much for chronic administration or for repeated bolus dosing. But what we do know is, fortunately, when we use an infusion, usually the concentration, the dose that we use is about 1/4 or 1/5 of what we will give by injection, right? When we use a ropivacaine infusion, we usually only use about 0.1%, as opposed to 0.5 or 0.75% of ropivacaine. So you know that the dose that we give per hour is much lower. So that is why we seldom would see toxic side effects from the hourly infusion. But I think the people we really have to pay attention Two are the people will be impaired liver function, kidney functions, and with heart failure, because they will have a harder time to clear. The clearance and metabolism will be slower in these patients. And generally speaking, again, we don't give the infusion for more than 24, 48 hours. So again, that is why we don't see people, many reports of toxicity. So the dose is lower, the duration is generally more limited to 24, 48 hours.
What about testing? Now, I was going through some of the literature, and there was this talk about, not in anesthetic circles, but other drugs, something called as volumetric absorptive microsampling, otherwise called VAMS. Now, we know that most of the studies which are done for local anesthetic blood levels use liquid chromatography or something on those lines. So, do you have any idea if anything like that is coming around for anesthesia? Because
you are ahead of me, so you have.
I was just trying to see if anything is happening on the anesthetic front as a point of care testing.
Oh, okay. Yeah, I personally, I would love to see point of care testing for many things. For example, for when we talk about regional anesthesia and anticoagulants, that is one thing we don't have. Is if we have point of care testing, then we will know what to do, right? Instead of having a guideline that applies to everybody, and we know we are all different, we are not the same. So point of care testing will be fantastic if we can get to know the individual levels of the drug.
And finally, I would like to ask you a little bit about lignocaine infusion. Now, we are speaking so much about perineural blockade, fascial plane blockade, but there is an increasing role. We know that in chronic pain circles, it is well established for neuropathic pain. And we are seeing an increasing number of papers coming out with lignocaine infusions, which are being given perioperatively in patients whom we cannot probably cite an epidural because of, as you said, anticoagulation issues or some other reason. So what is your take on this, in a few words on this, please?
So as far as I know, IV lidocaine infusion is good. There's sufficient evidence and many studies showing that it's good for abdominal surgery. Whether it's open abdominal surgery or laparoscopic abdominal surgery, it can reduce opioid consumption, it can reduce nausea and vomiting, it can promote recovery of bowel function and decrease the incidence of ileus. But as far as its use for, let's say, orthopedic surgery, a lot of studies on spine surgery, for cardiac surgery, for thoracic surgery, for ENT, even for breast surgery, those data are more mixed. And that's why we need to, again, use more time and do more studies to have a better idea. I think the current challenge is we don't even know what dose that is most optimal, what duration of administration is most optimal, or what blood levels that we need to achieve to be most effective. So those are the things we have to consider. When we don't see the effect, is it because the duration? Is it because of the dose? Single in bolus dose and also the continuous infusion dose? There's many variables. That's why we need large scale, maybe multinational studies to figure out this first before we can say it's working or not working. But so far we know it seems to work quite well for abdominal surgery.
Thanks a lot, Dr. Chan. It's been a wonderful 40 minutes plus, diving a little bit deeper than normally what we do into a subject which is always focused on procedural based intervention, learning the skills. Understanding the science behind what happens in a block is more important, as we have realized in the last 40 minutes. So thanks a lot for joining us. So probably just to summarize,
Test.
sorry?
I hope I passed the test. Oh, you give me an evaluation later on.
Now, the Indian Journal of Anaesthesia editor-in-chief should probably give you the certificate for passing this test.
I think there is certain people who doesn't need to pass and test because you are one of the pioneers in this area, and we are really privileged. And same would be the listeners today, because sometimes the pearls comes from experience. They may not be into the research publications. So I think each word is a pearl to us, and I'm sure that it will be really helpful to academicians, clinicians, and researchers also. So really thankful. Thanks so much to you, Dr.
Thank you for the opportunity.
Thanks a lot, Dr. Chan. Just to summarize for our listeners, I just wanted to mention a few points. One is use the minimum dose that is required for the patient, because we cannot understand the pharmacokinetics and dynamics in each individual, and we cannot understand the rate of absorption based on where we inject. So that is probably the first key point that people need to take from this conversation. The second is about the fascial plane blocks, and the young researchers have got a lot of new ideas today, listening to you as to where they can probably focus on. And also regarding the lignocaine infusion, for people who haven't used it much, it's a tool that you probably need to have, because that's a very good perioperative analgesic modality that is still underused. So thanks a lot, Dr. Chan, once again for taking your time off and joining us. And it is indeed a pleasure and an honor to be speaking with you on the podcast. Thank you very much.
Thank you. Thank you.
Thank you so much.
Have a good day.
So all our listeners and viewers, thanks a lot for joining us to this September 2nd episode. The first one was with Dr. Hari Kalagra, where we spoke about gastric focus and the evolving role with use of GLP-1 agonists. So till the next episode, which will be the author's episode, focusing on the October issue of Indian Journal of Anaesthesia. Stay safe, stay curious, and keep learning as always. Thank you very much.